Welcome back. This is Majid from Student Help. In this video, I'm going to cover primary adrenal failure, which is called Addison's disease. And towards the end of the video, I'm going to compare it with the secondary adrenal insufficiency. Please, if you like this video, consider giving us a like and subscribing to our channel in order to be notified with every video. So let's get started with revising the physiology behind the regulation of the adrenal cortex. Now, as you know, that the adrenal cortex is the bottom of an axis which we call the hypothalamic pituitary adrenal axis, or in psychiatric fields they call it also the stress axis, right? So as you know that the hypothalamus starts by producing the corticotropin releasing hormone, or what we refer to as the CRH, which is positively inducing the production of ACTH from the anterior pituitary, right? And then the anterior pituitary would respond by producing the ACTH, the adrenocorticotropic hormone, which is going to act on the adrenal cortex. Now, let's remember the layers of the adrenal cortex. The outmost layer of the adrenal cortex is zona glomerulosa, which is producing aldosterone. The middle one, zona fasciculata, that is responsible for producing cortisol. And then zona reticularis, which is responsible for producing testosterone. Now, what I want you to think about whenever we're talking about the stress axis or the hypothalamic pituitary adrenal axis, then we're mostly talking about cortisol. So when we have ACTH released acting on the adrenal cortex in a physiological case, then the main outcome of it would be an increase in the cortisol level, right? Although when there is a pathological condition where we have so much ACTH, when the ACTH level is highly elevated, it's going to have a very minimal activation of the zona glomerulosa to produce more aldosterone, right? But as you remember that the aldosterone is mainly regulated by the renin-angiotensin axis, not by the CRH-ACTH axis, right? So when we talk about the CRH-ACTH, we know that the outcome is mainly cortisol. But when we talk about the renin-angiotensin axis, we talk about aldosterone. Let me remind you of the renin-angiotensin very quickly. So when there is a drop in the pressure at the area of the glomerular area of the nephron, the juxtaglomerular cells would start producing renin, right? Renin is going to convert angiotensinogen that is produced from the liver to angiotensin 1 that is going to be converted by the angiotensin converting enzyme that is present in the lungs to the angiotensin 2. Then angiotensin 2 is going to act on the zona glomerulosa to induce aldosterone release, okay? Now forget about aldosterone for a second and let's talk about the axis a little bit. So we said that CRH is inducing the production of ACTH and ACTH is inducing the production of cortisol. Now, cortisol should actually suppress the CRH and ACTH because we have enough. So what happens is that there's going to be a negative feedback of cortisol on the production of more CRH and ACTH. This is a physiological process. Now, what is the main function of aldosterone that is produced from the zona glomerulosa? As we know that aldosterone, let me write it here. Okay, now, so aldosterone usually goes to the nephron, right? Now, aldosterone goes to the nephron and it increases water reabsorption together with sodium reabsorption. So actually it induces sodium reabsorption and then water follows, right? So reabsorption of these two, reabsorption. And on the other hand, it also induces the excretion of what? Of potassium and proton, right? So the net result of inducing aldosterone release would be increasing the volume that is coming from increasing water and sodium and decreasing potassium and proton levels, right? Now, on the other hand, cortisol that is produced from the zona fasciculata, it is very important to maintain something called the vascular tone. The vascular tone. So as you know that in the vessels there is smooth muscle, right? So this smooth muscle has a tone and cortisol, it tries to maintain that. Whenever we don't have cortisol, the vessels become more flaccid. So if we don't have cortisol, this would lead to vasodilation, right? This would lead to vasodilation. Just keep this in mind. I'm going to get back to it in a minute. Now, so the disease that we're talking about today is primary adrenal failure. What is a primary adrenal failure? It's Addison's syndrome. Now, why would someone have a failing adrenal gland all of a sudden? The most common cause worldwide, the most common cause in the developed countries, so in the Western world, the most common cause is autoimmune disease. Autoimmune disease, right? So the immune system all of a sudden starts attacking the adrenal gland for no reason, right? So this is the most common in the Western world, right? Western world. But actually worldwide, it is not autoimmune disease. Rather, it is infection. Now, what is the infection that would actually spread to the adrenal gland and cause the adrenals to become failing or insufficient? These are tuberculosis is the most common cause of adrenal failure worldwide, but also HIV or some fungal infections can also lead to that. Okay, but what I would want you to remember and never forget that these two are the most common, autoimmune and tuberculosis. We also have other reasons that might lead to the adrenal failure. For example, hemorrhagic reasons. Hemorrhagic reasons, right? For example, if a patient is using anticoagulation, so they are at a higher risk of bleeding and so on, or if the patient is infected with meningococcus. Now, if he's infected with meningococcus and then meningococcus spreads and causes sepsis, then meningococcemia can develop, and this can lead to failing adrenal gland due to ischemia, right? Now, what else is a metastatic cancer? So a cancer can metastasize to the adrenal gland and cause the adrenal gland to become failing. So metastasis, right? So this is most common in case of lung cancer. So lung cancer is very commonly metastasizing to the adrenal gland, right? To the adrenal gland, causing them to fail. When we say the word primary, this means that the problem is mainly in the adrenal gland, right? So it's not in the axis, it is in the adrenal gland. Primary adrenal failure means that the problem is primarily in the adrenal gland. So the axis is working perfectly. Now, we have a failing adrenal gland. This means that the cortisol level, what is going to happen to the cortisol level? It's going to decrease, right? So if we have a low cortisol level, right? So we have a low cortisol level. What does this mean? This means that the ACTH level is going to be high because the axis is actually working perfectly, but the adrenal cortex is failing. It is not producing cortisol, and therefore we're facing a problem with the inhibitory feedback of the cortisol. So there's no inhibitory feedback anymore on the ACTH and on the CRH. Therefore, the ACTH level is going to be high. Okay, in a primary adrenal failure, is the aldosterone affected? Now, yes, because now we're talking about the problem with the adrenal cortex. So the whole cortex is actually affected. The whole cortex is becoming pathological, not only zona fasciculata. Please focus that this is in the primary adrenal failure. We're talking about primary adrenal failures. The problem is primarily where? In the adrenal gland, right? Because if the problem was in the axis, then cortisol only would be affected, because as we said that aldosterone is mainly regulated by angiotensin, so by the renin-angiotensin system, not by the ACTH, not by the CRH-ACTH system. Therefore, when we talk about primary adrenal failure, just keep it in mind that all layers are actually malfunctioning. Zona glomerulosa, fasciculata, and reticularis. We will have reduction in the production of both aldosterone and cortisol. So aldosterone is going to be low. Okay, now, before going to the features, let's try to actually see what is the effect, okay, what is the result of having low aldosterone. So we said that aldosterone was responsible for increasing water and sodium absorption and decreasing potassium and protons in the serum. If we don't have aldosterone, the opposite is going to happen. What does this mean? That we're going to have reduced sodium and water, and elevated potassium and protons, right? Now, when we have low sodium and water, what does this mean? This means that we have low volume, decrease in the volume, right? So decrease in the intravascular volume. And when we have high potassium, this means that it is going to be with hyperkalemia, right? And elevation of protons means that we have metabolic acidosis, right? And we said that cortisol was responsible for maintaining what? For maintaining the tone of the vessels. And whenever we don't have cortisol, the vessels become flaccid, so they become kind of what? Dilated, vasodilation, right? Happens when there is no cortisol. Now, what do you expect? We're having vasodilation together with low volume. What does this mean to you? This means to you that if you go check the blood pressure of this patient is going to be what? Low. So if you see that a patient is having a low blood pressure with hyperkalemia and metabolic acidosis, right? This should raise suspicion of a failing adrenal cortex, right? Okay. So these are the features that we're talking about here, okay? So now, what would be the patient's symptoms in this case? How would the patient represent to you? So first thing is that they have low blood pressure. How would they represent if they have low blood pressure? They might have fatigue, right? They can't concentrate. They are feeling really tired, right? Now, but what is more characteristic and more important is the orthostatic hypotension. That basically, because there is no vascular tone maintained by cortisol, there's no cortisol to maintain the vascular tone. Whenever they stand up from a sitting position, their blood pressure suddenly drops, right? So this leads to dizziness whenever they get up from a sitting position or from a lying position, right? So orthostatic hypotension is very important. But also, if the adrenal insufficiency happened acutely all of a sudden, they might actually come with a shock. So with a hypovolemic shock, right? Very low blood pressure. And the body is going to be in a total distress. Okay. Now, other than orthostatic hypotension and shock, right? They might have some gastric symptoms, or let's call them gastrointestinal symptoms, because they might have very general symptoms like nausea, vomiting, or for example just abdominal discomfort, in addition to losing weight. So they would also lose weight. Why would they lose weight? Think about it like a patient who's being treated with cortisol. What would happen to them? They gain weight, right? So a patient who doesn't have cortisol would lose weight. Okay? Now, what else is that, which is very, very characteristic, very, very important in this case, is hyperpigmentation. What does this mean and why does it happen? Let's get back to the axis. Now, so as we said, that if we don't have cortisol, there's no cortisol, right? This means there is no inhibition of the ACTH. Therefore, the ACTH level is going to be high, right? Now, whenever the pituitary gland, the anterior pituitary gland, is trying to produce ACTH, it actually produces something else as well, which we call the melanocytes stimulating hormone, right? So these melanocytes stimulating hormone is going to lead to hormone, okay? So this hormone is going to lead to increase in the pigmentation. The patient all of a sudden is going to become what? Is going to become like tanned, right? Now, how can we know that actually this patient didn't get tanned from the sun, but he get tanned or she got tanned from melanocyte stimulating hormone? In this case, we have to check the what? The palms, right? Because I have never seen someone who, tanned in the sun or artificially and their palms were tanned. This doesn't happen, right? So therefore, if it is actually a disease, then even their palms are going to be tanned. So hyperpigmentation is very characteristic for primary adrenal failure. Why primary? Because in the secondary, okay, let's leave it in the secondary, right? I don't want to confuse you for now. So far we said that a patient came complaining of fatigue, orthostatic hypotension, and they might have come with a shock, and they are saying, okay, I'm feeling nauseous, and I had some episodes of vomiting, I have lost a couple of kilograms that I didn't even mean to lose them, I wasn't going on a diet or anything, and you check their palms, and there's what? Hyperpigmentation. What do you do next? The first thing you should do is a CBC, right? Like always, we do a CBC. Now, what will you see in the CBC, or what are you looking for? What you're looking for is basically that if we don't have aldosterone, then what should happen? There should be hyperkalemia, right? There should be hyponatremia, right? And what else? There should be metabolic acidosis, right? Acidosis. Now, what is extra is that we said that actually having decrease in the sodium and the water, this had led to decrease in what? Decrease in the volume. When you have a decrease in the volume, what happens to the glomerular filtration? Filtration rate. What happens to it? Of course, it decreases. So we have a decrease in the volume, decreasing in the glomerular filtration rate. Therefore, clearance of calcium is going to decrease. So the serum calcium level is going to elevate because there's not much filtration at the kidney. The serum calcium level is going to elevate. So in their labs, you're going to also find hypercalcemia. What else? You're going to find eosinophilia. Why is that? Why would you find eosinophilia? Well, it's not clear why, but it can be explained, for example, if it was caused by a decrease in the cortisol. Whenever there's a decrease in the cortisol, there's an increase in the eosinophil count, or because there's an autoimmune disease. But then you would ask, okay, if the primary adrenal failure was caused by tuberculosis, would we still have eosinophilia? Yes, in some cases you would still have eosinophilia. So it is not clear why actually there's eosinophilia, but it is found in many cases of Addison's disease. Right. Now, after we have seen all of these things, right, now what should we do next? How can we confirm that the patient does have Addison's disease? The thing that you're going to do next is to measure the cortisol. So you will have to measure the serum cortisol and ACTH level in the morning. Okay? So you're going to admit this patient, and then in the next morning, you're going to check the serum cortisol ACTH level. What are we expecting to see? If the adrenal gland is failing, cortisol is going to be low. And if the problem is actually in the adrenal gland, then ACTH is going to be high because there is no negative feedback, right? Okay, so we saw this. Is this enough to say, okay, the patient does have adrenal insufficiency? No, it's not enough. We need to go further and try to stimulate the adrenal gland. What stimulates the adrenal gland production of cortisol? ACTH. So we're going to give exogenous, right, ACTH analog. What is this ACTH analog? It is called concentropine, I guess. Let me double check. Concentropine. So this concentropine, we're going to give 250. You can just memorize it as ACTH test. Okay, so it is ACTH test, right? So we give the patient ACTH, we try to stimulate the adrenal gland. In a normal person, the cortisol is going to rise more than 20 microgram per deciliter. But in a patient with Addison's disease, the cortisol level is still going to be very low. And mainly, less than 20. What else? 20 microgram per deciliter. Okay? What else? That the ACTH level, their endogenous ACTH level, is still gonna be high. When we find this after a cosentropine test, this is confirmatory. So this confirms Addison's. This confirms Addison's disease. So again, a patient came to us with fatigue, orthostatic hypotension, GI symptoms, losing weight, and we saw hyperpigmentation at the palms. We do CBC, and after the CBC, we do serum cortisol and ACTH in the morning, and then we confirm the test with ACTH test, right? So we do an ACTH test. Let me just match the colors. So ACTH test. Right. So this is when the problem is within the adrenal gland. Now, what if the problem was not in the adrenal gland? What happens then? Or what do we call it? Now, in case of the secondary, right? In case of the secondary adrenal insufficiency, right? In the secondary adrenal insufficiency, this is the disease that you're going to be thinking about in the differential of Addison's, right? What does the secondary adrenal insufficiency mean? Now, from the name, you can tell that the problem is not in the adrenal gland, not the adrenal. Then what's the problem? The problem is actually ACTH. We don't have ACTH in this case. So if there's no ACTH to stimulate the adrenal gland, we don't have cortisol. Just makes sense, right? So the cortisol level is going to be low. The cortisol level is going to be low. Is the aldosterone level going to be low in the secondary adrenal insufficiency? No. The aldosterone is going to be normal. It's going to be normal. Why? Because we said that the aldosterone is mainly regulated by the renin-angiotensin system. But if the adrenal gland is the problem, that we have, for example, a tumor here, right? If we have a tumor here, of course the zona fasciculata and the glomerularis are going to be affected. But if it is not the adrenal gland that is the problem, but we don't have ACTH, then only cortisol is going to be affected, and aldosterone is still going to be working perfectly under the effect of renin-angiotensin system. Therefore, are we going to find hyperkalemia? No. There's no hyperkalemia. Right? Are we going to find hyponatremia? Tricky question? Yes, sometimes. Why? We said that the aldosterone is working perfectly, and now you're saying that there's hyponatremia. This doesn't make sense, right? Wait a second. Because when we don't have cortisol, this means that we have increase in the ADH. What? Where did this come from? Okay, let's go back to the axis. Cortisol does way too many things in your body. One of them is that it inhibits ADH release. When we don't have cortisol, there's an increase in the ADH release. So what happens when we have so much ADH? SIADH, syndrome of inappropriate ADH release, right? That's what happens. So because we are reabsorbing, what happens here? We are reabsorbing lots of water, right? But no sodium. What do you expect to happen to the sodium level in the serum? Sodium level is gonna drop, right? Okay, but don't get so confused. If you focused on the potassium and found no hyperkalemia, this is very suggestive that it is actually only secondary adrenal insufficiency. What is the other very important thing to look at in this case? In the secondary okay, let me color it. So in the secondary adrenal insufficiency, this is the different one, that aldosterone is going to be normal. And the other thing is, if we look at the ACTH level in the secondary adrenal insufficiency, what are we going to find? What are we going to find if we look at the ACTH level in the secondary adrenal insufficiency? The ACTH is going to be low. ACTH is going to be low again. Why? Because we just said that the problem with the secondary adrenal insufficiency is that we don't have ACTH. Comparing to the primary adrenal failure, where there's Addison syndrome, we said that the problem is in the adrenal cortex. Therefore, we had an elevation of the ACTH, and because the adrenal cortex is fully affected, aldosterone was low. But in case of the secondary adrenal insufficiency, the main problem is that we don't have ACTH, right? We don't have ACTH, therefore we don't have cortisol, but aldosterone is still working perfectly under the effect of renin and angiotensin, and ACTH is gonna be low because the problem is actually that we're having a low ACTH. Otherwise, the symptoms overlap, except for, are we gonna have hyperpigmentation? Let's think about it. Are we gonna have, what the hell? Right. Are we gonna have hyperpigmentation in case of secondary adrenal insufficiency? No, big no, big no. Let's make it bigger. It's even bigger, right? It is a very big no, right? So if you were to tell, like you're being asked at a bedside level, is this an Addison syndrome or a secondary adrenal insufficiency? What are you going to look at? You're going to look at hyperpigmentation. Is there hyperpigmentation? If yes, this means we have so much ACTH, right? Because we said that the melanocyte stimulating hormone is produced together with ACTH. It is not produced alone, right? So therefore, if we have hyperpigmentation, this is indicative of primary adrenal failure. If we don't, then this is a secondary adrenal insufficiency. What else? The blood pressure is going to be low here. Yes, of course, because we don't have cortisol. So there's a decrease in the blood pressure, but aldosterone is still working fine. So it is a mild hypotension. Mild hypotension. It would be more severe in case of Addison syndrome because both cortisol and aldosterone are low. So here we had two factors contributing to the low blood pressure, but in case of the secondary adrenal insufficiency, it is only cortisol, right? So aldosterone is trying to compensate here a little bit, right? Okay, so this I might have made this a little bit confusing with all of these, drawings. Anyway, let's give you a very quick overview. So we said that adrenal cortex is regulated by the CRH-ACTH axis, which has the main regulation on the zona fasciculata to produce cortisol. Zona glomerularis is also regulated by the renin-angiotensin system, which is totally separated from the hypothalamic pituitary axis. Therefore, if we have a problem with the adrenal cortex, like in a primary adrenal failure, then we expect both cortisol and aldosterone to be affected. Unlike the secondary adrenal insufficiency, when the problem is actually that we don't have ACTH, which means that only cortisol is going to be missing, but aldosterone is going to be still working perfectly under the effect of renin-angiotensin system, right? The main symptoms that we should look for is fatigue, orthostatic hypotension. Sometimes the patient is coming with a hypovolemic shock. GI symptoms like nausea, vomiting, losing weight because we don't have cortisol, and decrease in the volume as well. Hyperpigmentation is characteristic for primary, and first thing we should do is a CBC, looking for hyperkalemia only in the primary, not in the secondary, and then hyponatremia in both, and metabolic acidosis in a primary. Hypercalcemia can happen in both due to the decrease in the perfusion of the kidneys. Eosinophilia can happen in both as well. Then we find in the second test that we're going to do is a serum cortisol ACTH level in the morning, where we're going to find a low cortisol level and elevation of the ACTH in the primary, right? And then the third is ACTH test. Now, okay, so what is behind the secondary adrenal insufficiency? Why would someone develop secondary adrenal insufficiency? So the reason behind it is a chronic steroid treatment, right? Steroid use or treatment, okay? So if someone is actually treated with steroids for a long time, what happens is that because he's receiving exogenous steroids, these steroids are going to have a negative feedback on the ACTH release, right? Therefore, there would be no ACTH for a while. Okay, so there's no ACTH. Okay, what happens then? If there is no ACTH, then the zona fasciculata is gonna gradually die off. Zona fasciculata, right, is gonna die. What does die mean? It atrophies, right? So atrophy. Zona fasciculata atrophy is gonna develop due to the loss of ACTH, because ACTH is responsible for the growth of the zona fasciculata and for continuous functioning of the zona fasciculata. Right. For how long should the patient consume steroids in order to develop chronic steroid treatment leading to secondary adrenal insufficiency? It should be at least 3 weeks, right? So at least 3 weeks, and the dose should be 20 milligram per day. Okay, so if a patient has been treated with steroids for 3 or more weeks with a 20 milligram per day dose, then we expect them to have a secondary adrenal insufficiency. All right, so we saw that these patients had a low ACTH and a low steroids. So in the first step in the CBC, we would find no hyperkalemia, but we would find hyponatremia, metabolic acidosis. Would we have metabolic acidosis, right? No, we wouldn't have metabolic acidosis either, right? We wouldn't have hyperkalemia, because these were as a result of the loss of aldosterone. And we said in the secondary adrenal insufficiency, it's only a loss of cortisol. So here we would have hyponatremia probably, and decrease in the blood pressure, plus general symptoms like what? Probably hypercalcemia can develop due to the decrease in the vascular tone. So this is maybe not. And some general symptoms like fatigue and what? Fatigue and symptoms of GI disturbances, right? So would they have hyperpigmentation? Definitely not. So the big no here, right? Okay, so after this patient comes and we did the CBC, we saw this result. What is the next step? Same thing. We do a morning serum cortisol and ACTH, and we're gonna find low cortisol and low ACTH, right? Okay, what is the next step? The next step is that we do the ACTH test. Okay, so if we try to infuse these patients with the cosintropine, which is the analog of ACTH, would the cortisol level elevate? Would it elevate or not? It would not. Okay, so there is no elevation of cortisol, or it is minimal. What is important that it is going to be less than 20 microgram per deciliter, right? So this means that it is not an adequate elevation of the cortisol. So it might elevate a little bit, but it is not like the healthy elevation of cortisol in response to ACTH. Okay, and the ACTH level is gonna stay low. The ACTH level is gonna stay low as well, right? Because the ACTH is suppressed due to the chronic treatment. Now, why didn't cortisol increase by the ACTH test? Because the zona fasciculata has atrophied, so it is not functioning normally anymore. That's it about primary adrenal failure and secondary adrenal failure, and how to distinguish each, and the physiology and the pathophysiology background of each. I hope you guys like this video. Please, if you liked it, then support us with liking this video, subscribing to the channel, and probably consider leaving us a comment. Thank you so much for watching, and see you in the next.